Could you send it by email to him?
I will send. Sneha?
Jak on ci się wtrąci, to ty już nic nie powiesz.
Yes, sir.
On nie będzie miał głosu.
Let me see. I'll have to stop sharing my screen. Can you?
Wiesz, że ty
Okay.
jesteś moim czarnym koniem.
I'm Sneha.
Yes, sir.
I'm WhatsApping one email ID to you.
Yes, yes.
Just send the link to join to that email ID.
Yes, sure, sir.
Yeah, I have just sent it, Sneha.
Połączył się?
We will see. I think that he texts me if he connect.
Sir, it's time.
Hello.
Okay, everyone. I think, Ramesh, are we set to start?
Yes, sir.
Good
It's
evening,
exactly 5. Yes, Anand.
Good evening, all. Myself, Dr. Anand Bangar. I would like to welcome you all for this fetal surgery state of art webinar. It's 5 p.m. at Mumbai, India. And this webinar has been organized by Department of Pediatric Surgery, Lilavati Hospital, Mumbai, in association with Spanner Fetal Foundation. Department of Pediatric Surgery, Lilavati is a teaching institute with 4 trainees at present. Here we do all high-end surgeries with specialty interest in urology and continence surgery, along with hepatobiliary surgery. And all our trainees who have been trained here have been working in various cities in these countries and all over the world. Spanner Fetal Foundation is a non-profit for organization working for individuals with spina bifida for their treatment as well as rehabilitation. This webinar is in association with Indian Association of Pediatric Surgeons, Federations of Obstetrics and Gynecological Societies of India, and International Federation of Spinal Cord and Hydrocephalus. This webinar has been supported by Mayor Vita Biotics. I would like to welcome Dr. Santosh Karmakar to introduce this webinar. Dr. Karmakar, he is heading this department of pediatric surgery at Lilavati Hospital. He has been visiting fellow in pediatric urology at Children's Hospital of Philadelphia, visiting fellow at Alderhurst Children's Hospital, as well as visiting professor at Gassendi Children's Hospital, Genoa. He has trained various MCH and DNB students in pediatric surgery who have been working all over the world and this country. He has several publications and presentations in leading journals. He was honorary secretary of Indian Association of Pediatric Surgeons, and he is the founder trustee of Spina Bifida Foundation. I would like to invite Dr. Karmakar to introduce this webinar. Over to you, sir.
Thank you very much, Dr. Anand. Thank you for that warm introduction. And it is indeed a great pleasure to welcome all the delegates who have joined us from across India and many from overseas as well. So it's really nice that all of you are here to learn from stalwarts of fetal surgery. So I want to begin by making a small amend, and that is, we should not be calling it fetal surgery. So when I was preparing for this brief introduction for the webinar, I realized that the correct thing to say as far as this field is concerned is not fetal surgery, but maternal fetal surgery. Because this is truly the meeting point of the obstetrician and the pediatric surgeon. So we start with the amend. It should not be fetal surgery, but henceforth, we should all call it maternal fetal surgery. And I'm sure the large number of obstetricians who are with us today will readily agree with this change. I'm really excited because till today morning, we had more than 5,000 registrations, and that really shows the amount of interest that people have in this new and emerging field. It is over the last 50 years, actually, that pediatric surgery and fetal surgery evolved from just being an idea to what is now a perfectly viable clinical option. Way back in the 1970s, people did some fetoscopy to take fetal blood samples. And then with continuous innovation, with rigorous science and with some ethical contemplation, we have now reached a stage where several centers across the world are doing fetal surgeries. And I estimate that more than 100 fetal surgeries are being done in the world today. No one can talk about fetal surgery without acknowledging the immense work of this great gentleman who's seen in the picture here. He is Professor Michael Harrison, who started actual open fetal surgery and is considered widely across the world as the father of fetal surgery. And it was this book that he and his team published in 1984 with this really revolutionary title called The Unborn Patient, which really triggered interest in fetal interventions and fetal surgery. So no event which deals with this field can begin without paying tribute to Professor Harrison. I've had the privilege of speaking to him, not met him, but I have spoken to him via telephonic conversations. Professor Harrison is nearly 80 years old now, but he has ignited the spark of fetal surgery, which is being lit all across the world. What's happening in India? Well, we have been doing some sporadic fetal interventions for the past couple of decades. And I remember way back in early 2000, we did vesicoamniotic shunting at the Wadia Children's Hospital. It's only in the last 4 or 5 years that some centers are now seriously getting into establishing a proper fetal surgery program. And I must acknowledge some of my colleagues who are also on this threshold of starting fetal surgery. Dr. Abraham and his team from Kochi did some procedures in 2015, 2018. And the All India Institute in Delhi has also done some work. But I would not say there is a robust fetal surgery program established in any center in India yet. So India is on the threshold of taking off in this very, very new and exciting field. And therefore, friends, I think our fetal surgery, or sorry, I should say maternal fetal surgery program and this webinar is extremely timely. It's at the right time when obstetricians, pediatric surgeons across India will think of embarking on this new journey. With this brief introduction and without further delay, I want to introduce our keynote speaker, Dr. Agnieszka Pastuszka, who's a great pediatric surgeon, pediatric urologist, and a fetal surgeon from Poland, from a center in Katowice in Poland. Dr. Agnieszka is now amongst the top fetal surgeons in the world and probably is doing one of the largest numbers of fetal surgeries, certainly for meningomyelocele in the world. I have had the occasion of meeting her in her center briefly, and I realized that she is an extremely meticulous surgeon, a busy bee, you could say, does a lot of scientific work, clinical work, and also manages her home and family. And I found her to be very scientific in her approach. She has published work on fetal surgery, written chapters on this area, and she won the prestigious European Fetal Surgery Pioneer Award at the 38th International Fetal Medicine and Surgery Society meeting. So that indeed is a great honor for our keynote speaker today. And on behalf of all of us, I wish to congratulate her for this wonderful achievement and work.
Yeah.
I had the pleasure of seeing the work done in her center. And here we are about to start, or probably it was just after completing a fetal surgery procedure. Dr. Agnieszka is here with her mentor and professor, Dr. Janusz, who is also going to be hearing in this webinar today. So we are all excited to listen to the wonderful and very informative lecture by Dr. Agnieszka Pastuszka. So Agnieszka, the floor is yours, please.
Thank you very much for the invitation. It is a great honor for me to be with you, and I hope that I can show you our experience in the fetal surgery and prove that it is the reason to really perform the prenatal surgery for meningocele. Let me. Just a second. Okay, can you see my presentation?
Yes, but
Okay.
you could, yeah, we can see it well.
So I hope that at the end of this speech, you really believe that it is the worst to perform the prenatal surgery for spina bifida. As Santosh said, I'm working in Katowice. It is the south part of the Poland, and it is almost 6,000 kilometers from Mumbai. My mainly work is in the children's hospital, which is dedicated only for the children, but the procedure of meningocele repair in utero, it is performed in the slightly above hospital, which is situated in the Bytom, and it is performed on the department of the obstetric and gynecologists, which when the chief is Professor Anita. As we well know, not so far away, the obstetricians has possibility only to check the heartbeats or maybe receive the knowledge if it is one or more than one baby in the uterus. Since time of the ultrasound probe, we can know much more, not only how many fetuses are situated in the womb, but we can also look how the babies are involved, and we can also check if there are any disorders. Of course, we cannot check everything, but we can know lots about disorders, and some of them it is possible to treat before the baby is born. The three main ultrasound examinations should be performed first between 10 to 14 weeks of gestation, the second one between 18 and 22, and the last one between 30 to 32 weeks of gestation. For the millomeningocele, the most important is the middle one, when we can really identify the structural defects of the fetus. But we must remember that, for example, for the heart disease, the better view we can have in the first examination. Spina bifida, we know that is the most prevalent malformation of the nervous system, but it is the second most frequent congenital failure after the heart defects. So it's really, really very common. The prevalence worldwide ranges is between 0.3 to 5 per 1,000 of living neonates. What does it mean? Does it mean that there are any endemic places in the world? No, it's not true. The truth is that the differences depends on the possibility of prenatal diagnosis, as well that connected with the financial situation of the countries, and of course with the permission of the abortion of the pregnancy. So finally, I think that we can say that the real prevalence worldwide ranges is 5 per 1,000. According to the Hefe's two-hit theory, we know that this malformation comes in the two steps. First is connected with the wrong neurulation of the spinal cord, spinal tube, and it becomes very, very early during creation of the spinal cord. And the second damage comes during the pregnancy, when the permanent exposure of the spinal cord and spinal nerves to the amniotic fluid leads to the toxic damage, and the moving of the child in the womb leads to the mechanical injuring of the spinal cord. Finally, these defects leads to the total or parietal lower limbs dysfunction, which depends on the level of the spina bifida. Lower urinary tract and bowel disorders, and also leads to the hydrocephalus. Hydrocephalus is the result of the wrong circulation of the cerebral spinal fluid. And it is the result of the tethering of the spinal cord and moving to the back, the posterior part of the brain and cerebellum to the foramen magnum. So the question is, can we reduce the effects of this defect? The answer is yes, we can. How we can do it? By untethering the spinal cord and nerves, and by separating the spinal cord and spinal nerves from the toxic effects of the amniotic fluid and mechanic damages during the pregnancy. And this goal we can achieve only by performing spina bifida closure before the baby is born. The history of the fetal intervention is not so long. The first fetal intervention was performed in 1965 by Lilly, and he first made the replacement of the blood in the fetal with the conflict of RH. But as the Santosh said, the father of the fetal surgery and fetal intervention is Michael Harrison. He has just break a taboo that it is forbidden to make incision on the pregnant womb. He first performed the open fetal intervention, and it was performed in the baby with posterior urethral valve. He performed the vesicostomy. The pregnancy was finished on time. Unfortunately, baby was died, but the baby wasn't died because of the prenatal intervention. The baby died because of lung disorders. The fetal therapy is very quickly make progress very quickly, and now it's one of the quicker improvement field. When you check in the Medline library using the keywords fetal therapy, you can find thousands of papers about the fetal therapy. Where can we perform the fetal therapy, fetal surgery? There are two main points. One, in the case of defects that threaten to the life of fetus, and it is like diaphragmatic hernia, sacrococcygeal tumor, disorders of the lungs like cecum, posterior urethral valves, and twin-to-twin transposition syndrome. But we can also perform the fetal surgery in case when defects could cause permanent disability of a child. And in these points, we have the gastroschisis, hydrocephalus, amniotic band syndrome, and the main important spina bifida. How we can perform the surgery therapy for the fetus? We can perform by using shunting, by fetoscopy, or open fetal surgery. Shuntings are usually using in the case when we have the big cysts which disturb the appropriate involvement of the other organs. Like, for example, you can see here the big cyst in the thorax, which leads to the moving mediastinous organs on the left, and also disturb the proper development of the lungs. After shunting, you can see that the mediastinous organs come back and the lungs start to improvement. We can also use the shunting in the posterior urethral valves, but we must remember that shunting of the bladder in the posterior urethral valves is not for protect the urinary tract organs. We can do nothing with the bladder or kidneys in this case. The reason to perform the shunting in posterior urethral valves, it's only for receive the amniotic fluid, which is absolutely necessary for appropriate development of the lungs. Spina bifida. The history of the prenatal intervention of spina bifida is, of course, well known. We know that it was a trial of the moms, and in this trial attend 3 centers from San Francisco with Michael Harrison, from Philadelphia with Scott Adzik, and Vanderbilt with John Brunner. And the idea was to make the randomized trial for prenatal and postnatal surgery for myelomeningocele. And the results of this trial were published in the New England Journal of Medicine. And the conclusion were that the prenatal surgery for myelomenincocele reduced the need of shunting and improved motor outcomes in babies who underwent the prenatal surgery, but it was also associated with the maternal and fetal risk. And this trial was the first and the last one when the research were performed randomized way. Now, all this, our researchers, in all our researches, we compare the cohort group, postnatal operated group. What are the indications for prenatal intervention for spina bifida? The first one, and it is the point sine qua non, it must be single pregnancy. Even we have the twins and both of them have the myelomenincocele, we cannot perform this operation because it's too dangerous for a fetus and to the mother. Very important point, pregnancy age between 21 to 26 weeks of gestation. It is a therapeutic window. And it is unfortunately quite often happen that the mother comes too late for us. And we cannot perform this operation because over the 26 weeks of gestation, the risk of premature labor is increased very, very high. The level of spina bifida should be between TH part of the spinal cord to the sacral. When we start to perform this operation, it was said that it couldn't be higher than in the lumbar part. But now we know that we can also perform with very good results prenatal surgery when the spina bifida is situated at the level TH. None other serious malformation of the fetus. So if even we find something not very complicated, like for example, polydactylia or small disorders of the feet, it is not forbidden to perform prenatal surgery. The correct karyotype of fetus. And it is not clear completely because previously, yes, it was if we find any abnormality, we cannot perform. But during our last meeting in SEALS 2 years ago, we agree that there are some karyotypes disorders which can which shouldn't contraindicated the prenatal intervention for spina bifida. What's going on, for example, when we have Down syndrome and we didn't find any other disorders like heart disorders, duodenum disorders. Why we cannot help a baby, even the baby has two problems, we can maybe help even in the one which is a spina bifida. So even we find disorders in the karyotypes which are not connected with other serious disorders, we can perform prenatal surgery for spina bifida. One of the most important point is the hydrocephalus, which is present as Arnold-Chiari malformation. And if we do not have hydrocephalus, we should really, really think deeply if it is necessary, this prenatal intervention or not. Mother, of course, should be adult and she must accept this kind of treatment, she and her family. First of all, we have diagnosis with the ultrasound checking. And if it is found during ultrasound checking the spina bifida, we should send mother to the fetal surgery and diagnosis center when it is performed MRI and when we check the karyotype of the baby by the amniopunction. In our center, we have divided our job into two groups. The obstetricians prepare mother for the operation and performed the mother layers incision and open the womb. And after this, they, of course, close the womb and the mother layers and take care for the mother after the operation. And pediatric surgeons and fetal surgeons perform the operation of the fetus. About this part belongs to the obstetrician, you will hear in the Professor Olejek speech. Here you can see the mother layers opening. Here is the womb in the middle. The womb is taking off. And after this, with the ultrasound probe, we checking the position of the spina bifida. And it is performed the small incision above the spina bifida. The incision on the womb shouldn't be longer than the length of the spina bifida. So finally, we can see only the part of the dorsal part of baby when is situated the spina bifida. When the spina bifida is long, it's very often that the incision is shorter than the length of spina bifida, and then we situated sticks which help us to move the baby inside the womb. Actually, the steps of operation are not different from this one which are performed after the birth. But you must remember that here everything is really very, very, very small and very, very delicate. So our operation must be very delicate, very slow, and appropriate. First of all, we must cut off the myelomengocele sac, and after this, we must untethering the spinal cord. It's one of two most important steps during this operation, because only untethering the spinal cord and spinal nerves can give us effect which is the reduce of hydrocephalus. After untethering the spinal cord and spinal nerve from the scars with surrounding tissues, it is a very important thing to cut off the ligament connected dura with the vertebra. And when you do it, it's very often you can see when the spinal cord is moving up a little. And the second, here you can see the untethering spinal cord. Here is the skin, maybe. Here you can see, of course, all the cases are different. I very like this one with the big sac, the myelomengocele sac, because it means that the sac works like expander. So if I found in the MRI big myelomengocele sac, I can be sure that it will be no problem with the skin to cover the myelomengocele. Here is the open sac. And here you can see the dura. Usually it is possible to cover with dura the spinal cord, but sometimes the pieces from the right and left are too small, and we can only put the flaps of the dura. And the next step is mobilize and relax the muscles. It is very, very important to make it symmetrically, left and right. We must remember that at the dorsal part of the body, all muscles, even the smallest one, interspinal muscles, are in the pairs. And they works in the pairs. In case of spina bifida, it's quite often that one part is the left, for example, or right, is better innervated than the second one. So this could lead to the scoliosis. If we, during the operation, just put the flap not symmetrical from left to right or opposite, we can be almost sure that in the few years the baby involved the scoliosis. So we relaxed the dorsal muscles, usually is spinal erector muscles. When we are very high, it could be lower serratus muscles, or when we are very, very low, it could be gluteus muscles, but all the time symmetrically right and left. We don't make the flaps because in our opinion, it is unnecessary because it can disturb the function of muscles in the future. So in our procedure, we relax very slowly whole muscles and remove them to the posterior dorsal line just for cover the spinal cord. It is forbidden to cover the spinal cord with the dry tissue, like for example skin or with the Goratex flaps or something else. Because if we cover the spinal cord with the soft tissues, with the dry tissues, we can be sure in 100% that in a few months or years, we'll have untethering of the spinal cord. So if we are not able to cover in 100% the spinal cord with the dura, it is enough to cover it with the muscles, which are wet tissues. And the second point for cover the spinal cord with muscles, it is protect the spinal cord in the future, because we should remember that this operation, which is performed during pregnancy, should be the last one. We don't want to make it once again after the birth. Here you can see the suture of the skin. Here is the skin. Here is the womb. After the operation, it is insert saline to for replacing the amniotic fluid. And here is skin of the mother. And here how it looks the baby after the operation. Sometimes, especially when the baby is born a little bit too early, the scars doesn't look perfect, but usually it is very, very rare. In all these cases which were performed, it was happened 3 times where we have to perform the plastic of the skin, but only of the skin after the baby was born. In all cases, between 5 to 7 weeks after operation, we perform the control MRI for checking how is improving. We hope all the time that it is reducing the hydrocephalus, and we control the place of the operation. The ultrasound is performed much often, of course, usually 7 times after the operation. In our center, between 2005 and 2020, we have performed 186 open fetal surgery for spina bifida. And we have analyzed our results. And I would like to show you 3 analyses. The first one was performed for comparing prenatal and postnatal results due to VIP shunt needings and function of the bladder and bowel. We compared the 63 children operated prenatally and cohort group of the postnatally operated children. Of course, the level of spina bifida in all cases was the same, because you couldn't compare the results of operation when you have the spina bifida on level L5 to level L2. And what we have found, that the children who underwent the prenatal surgery need the VIP shunt twice less than this one who underwent postnatal surgery. All children, regardless of time of operation, prenatally or postnatally, receive the same protective urinary tract treatment, and it is anticholinergic, CIC, and urinary sanitizing drugs. And in this analysis, we compare results of ultrasound checking, cystoscopy, urodynamic tests, and degree of social urine continence, as well as presence of urinary tract infections and presence of constipation. We didn't find any differences between ultrasounds results and cystoscopy results in both groups, as well in urodynamic tests. What I must say surprised me very much, because in my opinion, these children who underwent prenatal surgery presents clinical much better condition. So we check also the social dryness, and you can see that the social dryness in children who underwent prenatal surgery was much better, statistically significant, better than this one who underwent postnatal surgery. And the same was with the obstipation. The children who underwent prenatal surgery suffered much statistically significant less from the obstipation than this one who underwent postnatal operation. These results were published in the Neurology and Urodynamics, but these results, they were only compared number of patients to number of patients. They didn't show what's going on with age. And we performed the next analysis, and I think it shows much better what's going on with age of the baby. And as you can see on the diagram, it's all children who underwent the prenatal surgery can receive social dryness, almost all of them. And this social dryness is increasing during the age of the patient. And the same happens with the UTIs and constipation when they become much rare in the children who underwent prenatal surgery than this one who underwent postnatal surgery. For these results, we receive the International Fetus Medicine and Surgery Society Award. The second analysis was for comparing neurological and neuromuscular outcomes, and they were connected with assessment of gait disorders. In these cases, in this analysis, we compare 16 children prenatally operated and 16 children postnatally operated with the level of spina bifida between L1 to S1. And as you can see in this picture, Here is the muscles of a child who underwent postnatal operation, and you can see lots of white spots. It means that in the place of the muscular fibers, we have connective tissues, and it is results of the wrong innervation of this muscle, is the quadriceps muscle, as well as here, when we can see that the view of this muscle is almost like in the healthy. When we compare sensory functions, the prenatal operated children has better results in sensory functions of spinal cord, on average one spinal segment. It means that even the level of spina bifida was between L1, L2. They present the sensory disorders like children who have the spina bifida on the level S3. And better, a little bit better was in the motor functions, when we are able during the prenatal surgery 1.5 segment of spinal cord. Of course, it is connected with the permanent disorder of the spinal cord and spinal nerves during the pregnancy. And when we check the gait of the children, we find that the prenatal operated fetuses after the birth during the age of 3 years present better motor development and they have better stability and mobility in the hip joint, what is of course connected with the better function of the muscles. And we have also published this result. And the last one, maybe the most important, because this analysis give us the answer why it happens like this. We analyze in the simple way, just histopathological checking the intensification of the inflammatory changes in the dura and in the skin. We check 45 patients from the prenatally group and 42 postnatally. The slides were taken from the tissues which are just surrounded to the spinal cord. And it was also important for us if there are any difference in between 22-23 and 24-25, because at the beginning, when we start our prenatal surgery, we performed operation earlier, between 22-23 weeks. Now we usually perform between 24-25. And we wonder if it is really necessary to perform this operation 2 weeks earlier, because we must remember that these 2-3 weeks, it can change everything. It's like a generation for the fetus. And during these 3 weeks, the tissues become much stronger and better visually based. So the operation is more, we can perform more carefully this operation and more delicate, and it is less danger for the baby when it is performed a little bit later. And in the results, we find that there is no difference in the time of the operation in the prenatal surgery, but it is very big difference between prenatal and postnatal operated children. As you can see, here are the inflammatory changes, lymphocytes and granulocytes in the skin, when we almost found nothing in the prenatal group, and we have found lots of inflammatory changes in the children who underwent postnatal surgery. The same we find in the dura. So we have also published these results in the journal Spinal Cord Medicine. So in the conclusion, I hope that I was able to prove that there are three reasons which can we really prove in our researches for which it is worth to perform prenatal surgery for spina bifida. The first is that the prenatal myelomegacil repair can, in the statistically significant way, reduce the risk of inflammatory changes in the spinal cord and nerves. The prenatal surgery, as the result of this, the prenatal surgery for myelomegacil gives a chance for better motor development and greater stability and mobility in the hip joints. And the prenatal myelomegacil repair can also improve the clinical condition of the urinary tract, therefore improve significant the urinary continence and reduce the risk of constipation. And all this literature after the prenatal myelomegacil operation in the future achieve better quality of life and self-esteem and independence. Let me show at the end a few photos and movies of our children who underwent prenatal surgery. As you can see, they look very good, move good. They do not have any intellectual disorders. This is 14-month-old girl. Look at this guy in the blue jacket. They can also biking. Catch me if you can. And here is the winner of the jump rope. Yeah. 53 jump. Thank you for your attention.
I hope you can hear the claps. Thank you very much, Dr. Agnieszka. Wonderful lecture, and I think you have conclusively proven that fetal surgery for many conditions, especially meningomyelocele, is a really safe, it is a viable clinical option and definitely has benefits. So who would believe that these children who are bicycling, who are skiing, who are jumping and doing the skipping rope have all been operated before they were born. So it's fantastic, and I must appreciate your huge experience of 186 cases of fetal surgery. So fantastic, and thank you very much. I think it has really inspired a lot of people who are listening today to embark on starting fetal surgery. We do have some questions, but we will take questions during the panel discussion.
Okay,
So
thank you.
we will move on to our next speaker. And let me share my screen again. Just give me a moment. Okay. So it's again a pleasure to welcome our next speaker. She is a professor, an obstetrician, and gynecologist, Dr. Anita Olejek. And in fact, when I remember, I did meet Dr. Anita also when I visited Poland, and she is the chairperson of the Department of Gynecology and Obstetrics and has been involved in doing fetal surgery along with the team and along with Dr. Agnieszka for so many years. She has been a participant in more than 180 fetal surgeries till date. And since 2019, she and her team have started fetoscopic surgery for spina bifida. And a large number of our participants today are obstetricians. And I'm sure, Dr. Anita, they are all looking forward to listening to your talk and giving us the obstetrician's view and perspective on fetal surgery. So, Dr. Anita, the floor is yours.
Thank you. Moment. Yes. It's okay? Can you see it?
Yes, we can.
So, thank you. So thank you for the invitation. It is a great honor to me to speak to such an excellent audience and so many people, especially that the subject we talk today is very, very important. I am really impressed also by Agnieszka's words because she's doing very much good works after the surgery and the works connected with following the future of the baby. So it is very important because it shows that our works is real good work. So Agnieszka told about meningomyelocele, and the very important thing is that this neural tubal defects occurs between 25 and 29 days of gestational age, so very early. And despite well-documented risk factor, MMC prevalence has not decreased notably. So we have still a big number, of course, when we talk about the whole world, a big number of children touched with this neurological defect. In Poland, our data shows that there is about 6 per 10,000 live births. What is the most important? And these children, without any intervention during the uterine life, are birth with many disturbances, with paresis of lower extremity, urinary and bowel incontinence, and also what is important, very much impaired psychomotor development. And the morbidity and mortality of these children is much higher than between the quite right children. As obstetricians, I would like to pay attention mainly to the most important facts for the obstetricians people, how to diagnose these disturbances in very early pregnancy. So the better time to diagnose is the first part of the second trimester. And in the ultrasound examination, we can see the changed shape of the head. So it's lemon shape. It is ventriculomegaly. We can also see the Manana syndrome, which is dependent. This is the picture of the cerebellum changed by this disease. There are some disturbances in fetus shape, foot shape, sorry. And so brain in spina bifida has this middle structures displacement and ventricle obliteration. So this is very important, and every obstetrician which is doing the ultrasound examination should think about these disturbances. So why to operate this congenital malformation in utero? So as the pregnancy progressed, the children became worse and worse. So it gradually lost the motor skills of the lower extremities. The hindbrain hernia progressed, and hydrocephalus is reported in the literature on prenatal evolution in very high degree. That these children has also future mental development on the lower level, and only half of them are able to live their independent life after coming of age. And that recently published data claim that intrauterine protection of the exposed tissue, so this nervous tissue of the spinal cord, may prevent some severe consequences of type 2 Chiari malformation. Here I'll also show you this ASIC work, because it was a fundamental work for doing this, surgery worldwide famous. Because it was a randomized trial, it takes 200. First, they planned to examine 200 persons, but they finished after 186 because the results were so good. And we started in our department this kind of surgery in 2005. So we were the first in Europe and the first in Poland. So I think that it is very important that we started to do it, because till today we have a quite big group of patients. The inclusion criteria Agnieszka just presented, they are changes in some details, but finally they are the same as Agnieszka said, so I will need to repeat it. But what is the most important thing? You have the team, the multidisciplinary team, to perform this kind of surgery. So it is not the work for one person, for pediatric surgeon, not for obstetrician. You can have a team. So the team consists of perinatologists, pediatric surgeons, neurosurgeons, neonatologists, anesthesiologists, internists who prepare the mother to the surgery, and psychologists, because the people, the family, the woman who is operated, she needs really psychological care and help. And at that moment, I would like to say thank you for Professor Janusz Bohosiewicz, who probably hears us, because he was the first person in Poland from the pediatric surgeons who agreed and who was very fascinated with this kind of surgery. And we started together at this 2005. So thank you, Janusz, because as far as I know, in Poland, many centers has problems still today with surgical pediatric surgeons who do not accept this kind of surgery. Of course, preparing the person to this kind of surgery, after this ultrasound examination, we do nuclear magnetic resonance as a first selection. After the surgery, the mother is also examined, and she also has nuclear magnetic resonance between 31 and 32 weeks of gestation in order to assess the evaluation of hydrocephalus, level of hypertension, and MMC recurrence. Also, there is very important to support psychologically the mother. And what is the most important, the patient needs very precisely information about the benefits and the risks of the procedure, because we cannot assure them that it's completely safe and without any risk. So we take on informed consent from both parents, mother and father, and also the family. It was requested by our bioethics committee at our Medical University of Silesia. It was in 2005, but we still continue this procedure because it is very useful, especially at the time when we have different law problems in Poland. So this picture shows some different kinds of malformations. I show you about these red points, so you can see here that there's low signal of nervous tissue. This is this MMC, and this is Chiari syndrome, hydrocephalus, and hindbrain herniation. As I said, this is the multidisciplinary work, but we are the group. So I mean obstetricians, the group who is responsible for the safety of mother and also of the child. So we have this to prepare this patient very carefully to avoid any complications or any possible complications. So a week before the planned operations, the patients received nifedipine. It is a calcium channel blocker in daily dose of 30 milligram. 2 days before MMC repair, patient received betamethasone in case of preterm labor to prepare the fetal lungs. The patients receive also progesterone vaginally in dose daily 200 milligrams. The patient receives also antibiotics prophylaxis, and this is 1 day before and 4 weeks after MMC repair. And we also receive relaxation of the uterine muscle by giving diclofenac natrium a day before the surgery, and we continue this 3 days after the surgery in oral dose 150 daily. The procedure is performed under general anesthesia and continuous epidural anesthesia without removing the catheter to facilitate postoperative analgesia, and these catheters stay till 3 or 5 days in mother's body. We also anesthetize the fetus, as I wrote it here. And what is important during the surgery, in case of uterine spasm and increased muscle tone, we can admit magnesium sulfate, atosiban, or phenterol intravenously to the mother. In this paper we published in 2018, you can find precisely and very good prepared written information about the pharmaco preparation the patients to this procedure. Anesthesiologists used for the general anesthesia sevoflurane. It is a very good gas because it causes uterine relaxation. So we have the next factor who can stop the possible uterine contractions during the procedure, because we have to think about some miracle. What was this surgery for me? So you incise the uterus, and you do something with fetus and you close the uterus, and the pregnancy will last longer. Yeah, it was for many years. It was said that when you incise the uterus, you need to deliver the baby, and there is the end of the pregnancy. Opening the abdomen, we opened it with the phalangeal incision, but we should remember that it is not this very low phalangeal which is on the mons pubic bone, because it is too low and it can cause the uterine artery closure. So it is about 4 centimeters above the pubis bone. Or sometimes we do the surgery in the scar after previous laparotomy. After the incision of the uterine muscle above the MMC, the amniotic fluid, of course, is evacuated because there is a leakage. So the volume of the uterus diminish a little. So you have to remember this before you plan the incision of the uterus, because the placenta suddenly became closer to the incision that you suppose before you started the incision. The incision is enlarged to do the field for the pediatric surgeon with autosuture stapler produced by USA, but since 2015 we had big problems in Poland to buy it, so we started the procedure using the Baquet staplers, following the Brazilian method. And the Baquet staplers, as I will show you on the picture, can do very good hemostasis, and the uterine muscle is incised with surgical knife or diode laser. So this is the first pictures on the left side. It is the abdomen opening. On the right side, we have the first step of the procedure. The uterus is out. You have, from obstetrician point of view, you have remembered that the uterine has to be wet. So we cover it with wet surgical scarf of shawl, and we keep it constantly wet, and we don't allow them to be dry. With the ultrasound equipment, we locate the placenta, because, as I said, it is very important to plan the surgical incision not too close to placenta. It should be about 5-6 centimeters since the age of placenta, because when you do it too close to placenta, the placenta start bleeding, or there will be the placenta abruption and the whole surgery finished. During the whole procedure, we examine the fetus with ultrasound equipment, and we examine their heartbeat, the umbilical cord works, and what is happened inside the uterus. This is the first incision. The first incision made, as I said, 5-6 centimeters from the edge of placenta. Here you can see the fetal membrane, and when we cut it, the amniotic fluid leaks. So the volume of the inside of placenta will diminish. The wall will stay not contract, not tense, but we have to remember about this diminishing of the volume of placenta, of the volume of the uterus, because of the placenta age. And after the first incision, we open the uterus. On the left side, you can see this procedure with the use of these American staplers, and on the right side with the Baquet staplers. So this is a very simple method and very useful and cheap, yeah, because this stapler cost in Poland about $500. The Baquet don't press the uterus muscle too much, so there is only the hemostasis, And between these Debacay staplers, we incise the uterus here with the surgical knife or with the diode laser, and we put the suture here behind these Debacay staplers to receive the hemostasis and to keep the fetal membranes inside, and to avoid the chorion ablation. Yeah? So this is very important. And after opening the uterus, you have the field for pediatric surgeon who they do their procedure. And after that, we close the uterine muscle with 3 layers of suture. Before the last suture is put, we supplement the amniotic fluid, and we also admit intraamniotically antibiotic. The whole time we control the hemodynamic condition of the fetus using Doppler ultrasound and analyzing the following parameters like fetal heart rate, PI indices, and RI of the umbilical artery to be sure that the fetus is okay. And these are the picture which shows that the closing of the uterus. So the first suture, as I said, there are 2 or 3 layers of suture. It depends on the situation. Usually when we use Debacay, there is 2 layers of suture. And before the last suture, during this catheter, the amniotic fluid and antibiotics and also diclofenac is put into the uterine cavity. The diclofenac we started insert a few years ago to prevent the prostaglandins activity inside the uterus. As we know, the prostaglandins can induce the uterine contractions, and they also are the reason to shortage the uterine cervix. And this is the end of the surgery in uterus. So it looks quite nice. Here you can barely see that there was anything done in the uterus. So it depends on the position of the line of incision and of their width. Postoperative care. After operation, all women are monitored for signs of intrauterine infection. They received antibiotic prophylaxis until 7th day. They also receive analgesic treatment, included marcaine through an epidural catheter till 3rd or 5th day, it depends. But we try to do it to move the patients from the bed as soon as possible. And tocolytic treatment include nifedipine 20 milligram per day, or phenterol 20 milligram per day, or in some urgent cases, we also use tractocil. Tocolytic treatment is continued through the remaining time of pregnancy in doses dependent on the uterine muscle tone. We also assess the whole time the fetal well-being with the use of a biophysical profile. So the midwives control the fetal heart rate 3 times per day, and every 7 days the lateral ventricular width, the level of herniation, lower extremal mobility, amount of the amniotic fluid, and possible chorioamniotic separation are monitored by ultrasound examination. So there is the best solution is where the patient stayed at the department at the hospital, and this is also done in other hospital. Or if the patients cannot stay in the hospital because, for example, for the money reason, they should be in the near of the hospital to be controlled very often. How is the determination of pregnancy? The determination of the pregnancy is through the elective cesarean section. And the cesarean section is performed at 37 weeks of gestation or earlier if there is any medical indication. But we have also the pregnancy which were finished at 38 weeks of gestation. We also carefully assess the uterine scar after hysterotomy during the cesarean section. I will show it here. So here is the baby and here is the uterine scar. As you can see, the scar is in very dangerous place. This is the fundus of the uterus, but the scar looks very nice. Of course, in other cases, the scars are on the front or on the back side of the uterus. And I would like here to show you some cases. These are the babies which are not operated intrauterine before, during the pregnancy. And these are the babies which we operated prenatally, and the results are completely different. What are the complications you are afraid of? So fortunately, we have not too many complications. We have only one case of pulmonary edema, which didn't require intensive medical care. And it was a time when we used magnesium sulfide to prevent the uterine contractions. We abandoned this procedure, so now we don't have any pulmonary complications. And there was one case of peritonitis resulting in necessity of cesarean section and revision of laparotomy, but the patient goes very well and there was no problem. And what was very, very important when we talk about the danger of this surgery, that we have no need of hysterectomy. So there was any complications which have to force us to do hysterectomy. So every patient have their uterus in their abdomen. And there was also no maternal death. It is also very important because when we talk to the patients and when we inform the patients and the family about this surgical procedure, a lot of women are afraid of themselves. They are afraid of the surgery. They're afraid of the results of the surgery. They are afraid if they don't lose their uterus. So there was no case of hysterectomy. During our post-surgical observation, we also observe the cases of chorioamniotic separation, which need to be very carefully observed. And in 20% there happened pre-labor rupture of membranes, but it doesn't mean that we finished the pregnancy. This pre-labor rupture of membranes, which were usually connected with chorioamniotic separation, when they happened without the uterine contractions, they don't need any actions. We just observe the patients. We do all the infectional examinations, and we can continue the pregnancy until the fetus is big enough and in good condition to be born. What is very important, so that complete healing of the hysterotomy side was observed during cesarean section in 75% of patients. So there was complete healing. So I mean also that the muscle width were satisfied. There was no place where the muscle is thin. And there was only few cases when the scar was very weak, and these places were just sutured without any complications after the surgery. And summarizing my speech, I would like to underline that this surgery during the last 20-30 years developed very, very quickly. We understand the stress mechanism of open fetal surgery much better. The anesthetic method improved. The colleague management and communication between members of these multidisciplinary teams also improved, and this all notably lowered the number of complications. And our study demonstrated low rates of maternal complications following anesthesia and surgery connected with MMC closure. We compare, of course, our result with other centers. We compared our result with MOMS trials, post-MOMS trials, with the results of many other centers in the US, which are performed actually, which South America, especially Brazil, with the European Center, and we can exchange our experience and improve our results. Of course, regardless, future studies on safety in maternal fetal surgery should be conducted still and evaluated as research. We were in Philadelphia in Scott Adzik a few years ago. It is Scott Adzik, and we probably knew this person. She's also well known. It's me and my assistant. And Agnieszka wasn't here with us because she was in other place in US. And Agnieszka is very good doctor. I'm very glad of her work because he is doing this very important work. I mean, so this follow up these children. So it is very important because gynecologists, obstetricians can do the procedure, but we need the follow up to be sure that our work is worth to be done. Thank you for your attention, and I also wrote here the contact mails to me and my telephone number if anyone would like to contact me and us. So we are glad to contact with you. Thank you very much.
Thank you, Dr. Anita. That was a wonderful lecture, and I really was impressed with your wonderful clinical pictures and also the various practical steps that you enumerated during the operation, after the operation, the care of the mother after the operation. I think that was something that the obstetricians who are listening in wanted to hear. So it was lovely lecture. Also the fact that you have no maternal deaths and no reason for hysterectomy. So I think that gives enormous confidence to people who want to start doing fetal surgeries with, of course, the team that you mentioned. The multidisciplinary team is also very useful and very important to give us success in this field.
Thank you very much. And I see here Professor Janusz Bohosiewicz, who was the first surgeon in Europe, first pediatric surgeon in Europe who did it. And Agnieszka is his student. So she's very well, she's very devoted to this procedure. And this is really a great group of surgical of pediatric surgeon, and the only one, I think, group of pediatric surgeons in Poland who do this procedure. Thank you, Janusz.
Yeah.
Thank
so
you,
let
Anita,
me...
for those nice words. But is this our common work?
Yes, so let me officially...
Yeah, but it needs
let me officially,
you know, a brevity. We have to be brave to start it.
Yeah, Dr. Anita, on behalf of all of us, I want to officially welcome Professor Janusz with us, who's participating. And Anita, if you can stop sharing your screen.
Yes,
okay.
Of course, it's okay.
Yes.
Thank you.
So before we start the panel discussion, at this stage, as we welcome Professor Janusz, who actually started the fetal surgery, and Professor Janusz is also the president of the Polish Association of Pediatric Surgeons. So welcome, Dr. Janusz. Would you like to say a few words, Dr. Janusz, before we start the panel discussion?
Few, very few. It is very nice to see you all, to see you before of all, and I hope we will meet in future. But now I'm old, I'm retired. The main surgeon is Agnieszka, fetal surgeon. So, but I like to cooperate with Anita, with Agnieszka, and I still be the senior looking for everything. But they are the future of this fetal medicine. Nice to hear you, nice to see you, and go to the next part of conference.
Janusz,
Thank you.
English said that you are retired, but you're still alive and kicking. So I'm very glad that you are in such a good condition.
Thank you.
Okay, let us move on to the panel discussion. And is my screen visible?
Yes.
Yes, it is.
Yes, yes.
Yes, Santosh.
Okay, great. So we have a wonderful set of panelists. And let me introduce to begin, to start, Dr. Shanta Kumari, an eminent obstetrician and gynecologist, well known throughout the country. And she also happens to be the president of the prestigious FOXY Association, which is the All India Association of Obstetricians and Gynecologists. So she is the current president, and we are indeed fortunate that Dr. Shanta Kumari, who comes from Hyderabad, which is a very important big city in the southern part of India, and she is going to be one of the panelists today. And you can see her various positions which she has held and the work she has done in this slide. So welcome, Dr. Shanta Kumari. Similarly, we have the president of the Indian Association of Pediatric Surgeons, Dr. Ravi Ramadwar, who is the current president of our Pediatric Surgeons Association of India. And he has a large experience in pediatric surgery, not only in India, but also has worked for 7 years in the United Kingdom, and is now currently working in Mumbai and is affiliated to quite a few leading hospitals in the city. Dr. Ramadwar is well known throughout India and of course in leading pediatric surgery centers in Europe and UK for his laparoscopic surgery. And he was the first to perform many laparoscopic operations in India. So welcome, Ravi, onto the panel.
Thanks, Santosh.
Last but not the least on the panel is Mr. Rohit Shelatkar, who's the director and vice president of the Vita Biotics Limited. And he is also the core committee member and has been a supporter of the Spina Bifida Foundation for the past several years. The support that Rohit and Mayor Vita Biotics give to our work of the foundation is passionate support which comes from the heart. And so I thought that on this panel, we should have a little different viewpoint of, and that is the reason to include Mr. Rohit also, because this is a new field where doctors, parents, mothers, families, everybody is going to be a stakeholder. And therefore we thought we will have him as a panelist and we will like to hear his viewpoint as well. In addition to these three, Dr. Agnieszka and Dr. Anita, of course, continue to remain on the panel and will be answering questions. We do have some questions from the audience, which we will take as we go along. But at the very start, I would like to ask all the three panelists to give us their initial views about both the presentations and, of course, their initial views on what they feel regarding maternal fetal surgery and its place in today's India, and where do we go from here. So initial thoughts, let me start by asking Dr. Ramadwar for his initial thoughts.
Thank you, Santosh. It's an excellent meeting which you have organized, and I must congratulate you and your team for this wonderful session. It's an eye-opener for us. So listening to this talk, I felt like I am watching Jeff Bezos and Richard Branson breaking the sound barrier and reaching into the space. And that is what our perception of fetal surgery has been, that it is difficult to achieve, and it's a very complex scenario and with a lot of risk involved. But I think we have the Jeff Bezos and Richard Branson in front of us, sharing their experience, telling us how it should be done and how it can be done. And I think it's a very, very motivating presentation. And I'm sure the youngsters from Gynecology Obstetric Association as well as pediatric surgeons should take this on board and take it forward from here. Thank you for organizing this wonderful talk.
Thank you, Ravi. May I request Dr. Shanta Kumari to give her initial thoughts?
Good evening. Thank you, Dr. Karmarkar. I think this has been a very interesting and should I say an exciting session. As Dr. Ravi has rightly put, fetal surgery has always been something which has been enigmatic. So all the obstetricians were always, we used to, as a postgraduate long time back, even we used to read and think that maybe fetal surgery is something as exactly put as Dr. Ravi. But now with so many innovations and I think the various progresses we are making, now fetal surgery, which is definitely not an easy subject, but both our speakers, Dr. Anita and Dr. Agnieszka, I happen to listen to both of them, a part of it. They have shown that it is not something impossible. And if you have the will and wish to excel in that field, you can definitely pick up that skill. So thank you, Dr. Anita and Agnieszka, for trying to make it look very simple. And I hope this has inspired many of my younger generation OB-GYNs to also look at it as a field which they can excel. Thank you.
One more quick sub question, Dr. Shanta Kumari. So do you feel that our major centers and institutions are adequately equipped now to take fetal surgery, the challenge of fetal surgery? Do you think we are fully capable? Any comments?
Yes, that's a very interesting question, Dr. Karmarkar. When you look at obstetrics and when you're talking about fetal surgery, what is it that is needed for obstetrics in India? Say we have a 1 billion population, we have millions of births, we have over 25 million deliveries taking place. Obstetrics is full of challenges and there are a lot of issues which we have to actually address right now. Even basic things like, anemia, hypertension, diabetes mellitus, nutritional disorders. So when we are trying to combat all this and the other major problem, PPH and these issues, these are very vital for the maternal health, to reduce the maternal morbidity and mortality. We feel that fetal medicine is a specialized field. It has its own place, but it doesn't mean that every obstetric center should go ahead and think that they should have a fetal medicine, fetal surgery center. It would be perfectly okay that if we have few specialized centers with some specialized people who can actually address this issue. So we are not looking at all the obstetric centers in the country to offer fetal surgery. We need to have few selected with the right people, with the right technique to be served to the right patient who is in need of it. So that is my take even as a president of Foxy, and I'm very clear because there are so many other issues in obstetrics which we need to actually address in our country.
Yeah. So Dr. Ravi, your thoughts on this about centers starting fetal surgery?
I think I would agree with Dr. Shanta Kumari with the lectures which we have heard today with Professor Agnieszka and Professor Anita. It is very inspiring to see the kind of work that is possible in a good clinical setting and with excellent results with zero maternal mortality, which is a wonderful goal to achieve. But as she has said that we have such a varied population, such a large volume of workload on people. So everybody should not think of getting onto this. We need to identify maybe 2 or 3 centers to start with, identify youngsters who are keen to take on with this specialty and send them to stalwarts like Professor Anita and Professor Agnieszka, get them properly trained so that we have a proper team which then sets up the service, which is then actually cleared by the ethical committee of the hospital, legal issues are sorted out, and then only we can take it forward from there. I know that there have been a lot of attempts in the past of fetal intervention in the form of putting up shunts or performing single port in procedures like PUVAL ablation or putting in vasoamniotic shunts. These have to be supplemented with proper training and proper equipment. We do have certain equipment which is specific for these procedures. We need to adapt to local conditions and procure this equipment, train youngsters in the best possible way to provide this service at the most safe and feasible procedure or treatment option for patients which have fetuses with different anomalies.
Yeah, right. So let me go on to Mr. Shelatkar. You, I know, have been following developments regarding prevention and care of birth defects, especially since you have been associated with the foundation for the past several years. So we would like to hear from you as a person closely associated with birth defects and as a person who's into micronutrients and nutrition, your thoughts about this new development and about the presentations today.
The presentations were fantastic, and no words to describe that. In my view, being from the nutraceutical industry and from the industry background, I can give you the industry's view on fetal surgery, neural tube defects, and how does the industry look at how the community is responding to that, how the regulators are looking at these interventions. Basically, the nutraceutical and the pharmaceutical industry now are working together. Major pharmaceutical companies and nutraceutical companies like Biotobiotics have invested in research in this area of neural tube defects. Prevention and cure just go hand in hand. If something is preventable, we must make sure we do everything in our power to give our patients the best possible chance for healthy life. The nutraceutical industry has done a great deal of work, especially Biotobiotics. We have contributed a huge amount to bringing awareness to general public about the importance of nutrients such as vitamin B12 alongside folic acid in the prevention of birth defects. We have been involved in the research that supports the use of not just folic acid, but also vitamin B12 in the prevention of neural tube defects in babies for over 40 years now. We have played a significant role in lobbying to health authorities in making national recommendations to official recommendations for folic acid and B12 in pregnant women. But there is still a lot of work to be done in this area, making sure that there's a worldwide awareness about spina bifida and other neural tube defects associated with nutrition deficiencies. And we're absolutely committed to doing that. The acceptance of folic acid as a risk-reducing drug, both relied upon, has helped to advance this development of preventive and clinical practices concerned with women's health before pregnancy as well as during pregnancy.
Yeah, right. Dr. Anand, are you there? Are there any questions from the audience that we can take in now? Hello?
Hello.
Yeah, yes, Anand.
Yes, sir. There are a few questions.
Yeah, please ask them.
Question from Dr. Mohan Abram is, what is your opinion on fetoscopic repair of meningomyelocele?
Okay, great question. So I think maybe Dr. Agnieszka could answer that.
Yes, we have already started with the fetoscopy procedure, but we performed this kind of fetoscopy, which was started by Jose Peiro in Cincinnati. We have already visited him, And we don't perform this procedure which was started by Thomas Cole. And most important fetal centers disagree with these methods because they perform methods through the skin. And in this method, it is impossible to close the fetus membranes and close the uterus. After this procedure, you have a long time of leakage of the amniotic fluid to the abdominal cavity of the mother and to the opposite. So the risk of infection is very, very high. And this method also, it's impossible to perform when the placenta is localized on the front of the womb. And what is, we have the experience, which was very important for us, when during perform the fetoscopy, we have a bleeding. So it was very, you can very quickly can open the womb when you have the womb outside, because even we perform the procedure, we take off the womb above the mother layers. So we start with this procedure, but not all cases could be classified for the fetoscopy. It depends on how the mesomeningeal sac looks, how it is, how old the pregnancy is, and also how the fetus is situated. But we have already started, but mostly we still performed open fetal surgery. But I think if you want to start with the fetoscopy, you first should start with the open fetal surgery because you need the experience. The steps are first performed the operation of spina bifida in the newborns. When you achieve enough experience, start with the open fetal surgery and the next step, fetoscopy.
I think Professor Janusz has a comment. Yes.
Maybe I am conservative, but I am against the fetoscopic operation up to now. And I know that the fetoscopy will come, but now we need only 5 centimeter opening of uterus. And the surgery of mesomeningocele is very delicate and perfectus operation. And for us, it's very important to do this fetal surgery perfectly. In our observations, the fetal procedure done around the world are not so perfect from the point of view the fetus. Up to now, to fetoscopy are need 3 holes. 3 holes in common give it's 4 or 5 centimeter. So I am conservative and I stay on the place of open fetal surgery. Maybe in future we will start fetoscopy. Maybe Agnieszka, not me. Thank you.
Yeah,
I have already started. You know it. But,
okay, let me ask Dr. Ravi Ramadwar and then Dr. Anita. Dr. Ravi Ramadwar, I remember when laparoscopy started, there was a lot of hesitation, apprehension in bringing it and doing complex operations. You are a great laparoscopic surgeon, so maybe your views on fetoscopy, fetoscopic surgery versus open fetal surgery.
So Santosh, thank you for asking me my opinion. This is a very, very important area for everybody to understand. We are at a stage where fetal surgery is non-existent in our country. So we need to train our people to do fetal surgery safely and properly with excellent results like what Professor Agnieszka and Anita have shown. So unless we are able to prove that we are able to do these operations by open method, by hysterotomy method, I don't think we should be thinking of doing fetoscopic complex surgeries. Fetoscopic surgery is like putting in a balloon in the trachea for a diaphragmatic hernia, or inserting a shunt, or ablation of the posturethral valve using a laser. Is a single port using a single trocar, which is simple, has been proved to be very effective for years together. But complex reconstructive surgeries, inserting multiple trocars in the uterus, has got a significantly high complication rate. And I don't think we are ready for that kind of situation. Our guys need to turn basics first, and then only we should think of going on to something which will let Professor Agnieszka and Anita show us that yes, it can be done by endoscopic method also in future. Then we should think about it. It's too early for us to think about it right now.
I think that's a very, very sensible view. Dr. Anita, you wanted to say something on this important aspect,
Yes.
important question.
Yes, thank you. You know, I'm also involved in gynecological oncological surgery, and I remember our gynecological meetings 30, 40 years ago when it was told that there is no place for laparoscopy in gynecology. And actually we do nearly all procedure endoscopically, and probably the same situation will be with this fetal surgery. But actually we have very well experienced with open fetal surgery. And the second thing is the price, because fetoscopic equipment is very expensive. So you have to be very careful not to damage it. You have to be very skillful to use it. So I think that if you try to start it, maybe the best way would be to try it by open fetal surgery. In Poland, we also have very situation when our colleagues said, "Oh, it is so awful surgery, so big cut of maternal abdomen." It's not true. It is the normal scarf like after the cesarean section, but the advantages of this open fetal surgery is the time. We do it in less than 2 hours, and fetal surgery lasts 4 hours or more. So actually, I think that there is also the problem in fetoscopic equipment. Thank you.
Yes. Yeah, Professor Janusz.
Know the way to the uterus is the most important thing. The most important thing is precision surgery for myelomengocele of fetus. If you will do this procedure by fetoscopy, but exactly on the way like pediatric surgeons are doing myelomengocele in neonates, then you can start fetoscopy. Before it, the open surgery, in my opinion, is better. We can to deter this. We can to do more perfect this operation by open surgery than the fetoscopy. What will be in future, we will see. Thank you.
Okay. Let me ask the host, our technical person, to unmute Dr. Mohan Abraham.
Okay.
He is also part of the audience, and we can get his views. He is another leading surgeon from South India, and he is on the verge of starting open fetal surgery too. So is Dr. Mohan Abraham there? Has he been unmuted? Okay, till he joins, let us go from this dilemma of fetoscopic versus open to another aspect which is of practical concern to us when we think of fetal surgery. So I'm going to ask both Dr. Agnieszka and Dr. Anita to tell us how easy or how difficult is it to convince a mother who carries a fetus with a malformation, neural tube defect. How easy is it for you to convince her for fetal surgery, and how do you go about it? Dr. Agnieszka first.
Yeah.
Or maybe Agnieszka, we should ask Dr. Anita first as the obstetrician.
Yeah, because thank you. Because the first diagnosis is made by obstetricians.
Yeah.
So we present the mother the fetal congenital malformation, and she is usually shocked, yeah, because it is very bad news for her. And she's answering us what to do, if we can do something and what will be the results. So we explain her. Also do the same our colleagues from other cities, other places in Poland. And if the mother decides to operate her child, she just go to our hospital and we talk to her as gynecological team. Agnieszka is also talking to her. She's checking the results of MRI examination, and she's presenting the future results and the future prospect for the child. And she's also proposing, and she's also organizing the future work with the child. So the pediatric surgeon is a very important person in this process of preparation, because we can convince the mother to operate the child, but Agnieszka has to show the mother and to explain her what can happen after the surgery and what are the prospects for the child. It is not easy, but a lot of mothers, especially the person who are religious, they want to help the child. They want to save the child. And in the past, when we can stop the pregnancy, when we could abort the pregnancy, the decision was easier. But nowadays, when this abortion in Poland is forbidden, I think that the number of patients who will decide to operate the child will increase. So I think that Agnieszka will explain more. Thank you.
Thank you, Anita. Of course, the obstetricians start discussion with the mom. We have to remember that pregnant woman is under control. It's just atavism mechanism which ask her and for saving the baby. So we must be very delicate, but we must be also very honest with the mother. We must tell her that this operation is not the operation like the cutting the nails and everything will be okay after the operation. We must explain her that we can only reduce the results of this defect, but we are not able to make the operation which make a baby completely healthy. And the other thing is just to show her what are the other possibilities of the treatment. Mostly 90, if the women came to us, usually she's looking for the dissolving of this problem, and mostly they agree for the operation before they came to us. But sometimes you must be very delicate, and sometimes you must have enough time to come once again to explain her what the good and worst point of this operation.
Dr. Shanta Kumari, any thoughts about getting consent for this surgery from Indian mothers?
Yes, Dr. Karmakar, thank you. Honestly, there was a very pertinent point which Dr. Anita mentioned. I don't know whether you would have picked it up, about the abortion law. See, a woman's sexual and reproductive right, that's what we, Foxy and FIGO, are always trying to make it very clear. At the end of the day, it's a woman's sexual and reproductive right. It's her choice to decide when to have the baby or not to have the baby. That is something which is very important. And unfortunately, we find globally, world over, there are some countries which don't offer the woman her rights. So in those situations, she's absolutely right that mothers look at a choice to see what is best in the given circumstances. But when you look at Indian scenario as such, probably, and one more very...
Hello?
Something with the voice.
I think Dr. Shanta Kumari is lost. Her net connection, I guess.
Yes,
Hello,
sir.
Dr. Shanta Kumari, are you there? Okay. No issues. We'll go on. Dr. Anand, any more questions from the audience?
Hello.
Yeah. Yes,
Hello.
Dr. Anand.
Hello.
We can hear you with a nice echo, but go on. You can ask the question, please. Hello. Anand. Okay. Let me ask a question which has come into the question answer box. And this is about not meningomyelocele fetal surgeries, but about experience of doing any other fetal surgeries. And the person is asking about diaphragmatic hernia. So Dr. Agnieszka, any thoughts about other fetal surgeries that you may have had to perform or have done, intervention surgeries?
Our center specialized in meningomyelocele repair, as we talked about. And as Dr. Shena Savant, I think, or the doctor who just diminished, she told about organizing the specialized center, and this is true also. Oh, sorry, Dr. Kumari. It was also underlined by Dr. Adzik concerning the USA centers, that the most centers will be organized, the lower effects will be achieved because the skills will be lower. So it is better to organize some single center, like for example in Poland, it's not a very large country. And we have other centers in Poland, for example, in Warsaw, our colleagues, they operate this diaphragma hernia, yeah, with some balloon. And we even have these patients to delivery. So our neonatologist was very skillful, and he managed to remove this balloon from fetus trachea to save the baby. The other centers did TTS syndrome, so this fetal transfusion syndrome. So in Poland, we don't intend to organize the multi-surgical center. Every clinics, every center do their own work to try to become the best in this area.
I think, yeah, that's very true. I mean, you better to be
you cannot be the master of everything. Yeah?
Everything, and
it is
there is
it is impossible to improve your skills when you perform the procedure once a year. If you want to improve your skills, you must perform it very, very quickly. And it is not only thing to perform the operation. It is very important to take care for the mother, baby, before and after the operation. So absolutely, you must work in groups and all around the world, everywhere we have the same situation with the fetal centers. Not everybody can say, okay, I haven't done it previously, maybe I will do it now. It's not a good way.
Yeah, absolutely right. Let's go back to Dr. Shanta Kumari, because she got cut off due to some net issue. But Dr. Shanta Kumari was speaking about convincing Indian mothers about fetal surgery. Yes.
Thank you, Dr. Karmakar. I had a power cut suddenly. So that's why I went offline and I'm back. See, when we look at Indian scenario, but I think not only Indian scenario, world over, every mother is the same, and every mother's wish to have an healthy baby is absolutely the same world over, be it in US or South America, Europe or Indian. But the issue is, how can we offer her the best surgery? So the technical skill, the financial aspects, these are very, very important. And that will play a very important role when you are trying to convince the mother. And the mother, the family, all of them have to be convinced. But before that, the obstetrician has to be convinced that she can offer her patient, the mother, to be probably the right way down. I think that is very important. We need to actually, as Dr. Agnieszka told, everybody need not be fetal surgery specialists. We don't need everyone to be a specialist. We may have a handful of them and who are experts, who are good, who can deliver the perfect result. So these two are interlinked, and that's how I think is the way forward which we can offer to our mothers.
Great. We do have several questions from the audience, but I'm going to do the difficult task of selecting few, because we don't want to overshoot our time by too long, because then the interest will drop out. But a few interesting questions, and anybody on the panel can answer. What do people feel about interventional radiologists performing interventional fetoscopic procedures? Should interventional radiologists be able to do some of these fetal interventions? Maybe they are talking about the percutaneous fetoscopic procedures. So any thoughts from anybody in the panel?
I think that it is not so easy because, for example, in open fetal surgery, the fetus is stabilized, so in one position, and it cannot move. In fetoscopic surgery, they use the special suture to stabilize the fetus. So also for any radiology, interventional radiologist procedure that could be done, the stabilization of the fetus is necessary. So maybe through the anesthesiologist, I'm not sure, but I also would ask what kind of procedure this person have on mind.
Okay, Dr. Ramadwar.
Thanks, Santosh. I think it's a very important question. One basic slide which was presented in the wonderful lecture which Professor Anita has given, as well as Professor Agnieszka has given, that it is a team approach. It is not a single person who is going to do everything for the baby. So the role of radiologist may be in helping in sonography, in preoperative MRIs to assess the anomalies, assess the extent of the defect and explain it to the surgeons, as well as to the obstetricians to plan their intervention properly. But on his own, I don't think an interventional procedure can be done on a fetus by interventional radiologists without the support of the entire team, which is necessary for this kind of procedures. It is a team approach. It is not a single person doing everything.
Can I just, Dr. Ravi and Dr. Karmarkar, I just wanted to add it. Maybe probably
sure.
when Dr. Karmarkar was mentioning, what he meant by interventional radiologists, there are fetal medicine specialists, obstetricians who are doing this work. So probably maybe the obstetricians who are fetal medicine specialists who do this interventional surgeries, I think that some of them which can be dealt, not the major aspects. So Dr. Agnieszka and Dr. Anita, your take on this.
But actually, some kind of the radiologist's intervention in the fetus are already performed in the cardiac disorders.
Mm-hmm.
Yeah. So I think the consensus is that it's not a one person's job.
Yes.
It has to be a team approach, and we have nothing against interventional radiologists if they want to be a part of this team. So I think that few more questions which I think are important. What is the incidence of fetal loss and prematurity after fetal interventions? The number of fetuses, fetal loss. Dr. Agnieszka.
I think it's very, very important questions. And we prove it in our paper about a learning curve. as we start, we compare two times at the beginning and now. And at the beginning, we have quite big morbidity, about 10%. Now it is less than 3%. So it's a learning curve. And if you must build the team, because we all learn from each other. And if you want to achieve really good results, you need time and experience.
And I would like to tell that there was no so many cases of fetal losses, because it is important that there is only few fetal deaths because of premature labor.
Premature, yes.
It was not during the procedure, but for example, the day after procedure or few days after procedure, when the children was, for example, 25 weeks, and it was the very low prematurity. So there was some bad results. But actually, about 80% of children are born over 34, 35 weeks. And we also involved this procedure with diclofenac. I presented this paper, and it does a very good work, and we received much better results. So actually the percent of premature labor is really low.
Okay. Two more questions. Any cases where you had to operate again after birth, Dr. Agnieszka?
Only 3 cases need the small plastic of the skin, but none of them need the second operation of the myelomeningocele. Of course, some of them need the VIP shunt implantation, but it is not the second operation of the myelomeningocele. It was never happened.
Okay. Dr. Anita, a question for you. Any cases of uterine rupture
After the surgery?
after the fetal operation?
Yes, we have 1 or 2 rupture in the place of skin, but it was in danger, and these children were born alive. So we have to remember that this is not a rupture of the normal uterine muscles, but it is the rupture in the place of scar. So it is usually not very well with very good blood supply, and it was no danger for the fetus or for the uterus and for the mother. So it was only a few cases. 75%, as I presented, there was no any damage in the place of scar. So this 25%, the scar was thin, or the scar was ruptured. But there was any danger with, as we see about the uterine muscle rupture. Yeah, it is connected usually in normal obstetrician practice. It is connected with huge hemorrhage and many complications. It doesn't happen in these cases.
Okay.
So it is not dangerous. Yeah, so you don't need to be afraid of these complications.
Okay. Dr. Anand, any questions that you have selected? Any more questions? We'll just take 1 or 2 questions more, and then maybe a comment from the panelists if they want to, and then we will have the closing remarks by Mr. Rohit Shelatkar. So Anant, do you have any questions with you?
There are a few questions about medico-legal issues arising of this fetal surgery.
We can ask that to all the panelists, whoever would like to answer any ethical and medico-legal issues related to maternal fetal surgery.
Yeah, I will answer this question because at the time when we started this procedure, it was 2005 and it wasn't approved procedure in Europe. So we received the ethical committee at our university agreement for this procedure. And we still use this in our everywhere when we publish our results. But after 2011, when Scott Adzik published the results of their study, MOMS trial, this procedure became worldwide known. And it is actually, I think that it doesn't need any ethical agreement. It is just a normal procedure. In our country, for example, it does in our health service catalog doesn't exist this kind of procedure, but we are paid by our health service in a special way of paying. So it is not, there is no problem.
Okay, anyone else wants to comment briefly? Anybody on the panel? Dr. Shanta Kumari?
Yeah. Right now, sir, there are no legal laws or something pertaining to fetal surgery. But we have seen everything, you know, for example, even ART, when it started off, we didn't have the law in place and then things used to happen. But once it started and then the government realized that we need to actually regulate, then the ART bill and all those modifications are coming into place. Same, so I'm sure the fetal medicine surgery also will, once it takes up and shape in the country, because now very few procedures are being done. I'm sure then the medical legal aspects will fall into place. And I'm sure Dr. Ravi also will agree with me. And I think till then, all the obstetrician gynecologists need to be aware of what are the laws and regulations in your own country. So we need to know what is happening in our country before we go ahead and do something.
I think that it may be safer, yes, safer for the doctors to have this ethical committee agreement.
Yes.
But we can
I
also
think,
say that,
yeah, yes, Agnieszka.
we can also say that if there are not contraindication for this treatment for the baby, it is gold standard for the baby, because we can prove, not only we, all fetal centers which performed the fetal surgery for spina bifida, proved that the results after prenatal surgery are much better than after postnatal surgery. So I think that it's unethical to forbid a mother underwent this operation if she needs, if she wants and needs it.
Okay. Can I again check if Dr. Mohan Abraham is there and would like to comment?
Santosh, can I make a comment in the meantime?
Yes, yes, of course.
We are facing difficult laws in our own country. One of the important law we are facing is the PCPNDT Act, where we can't diagnose many things antenatally, or we can't label the sex of the baby. So we need to have proper legal framework and to make sure that these kind of services can be provided in a safe environment for the patient as well as for the medical professional. So I think maybe it is a time for FOXI, IAPS, Neonatology Forum, Radiology Association to come together with the Fetal Medicine Association and form a group which will set the guidelines on which centers should be allowed to do these things, how they should train, and how the services should be set up very safely, so that we prevent any further issues related to legal aspect of these care. And I think it's a very, very difficult aspect in our country that various laws have actually created a lot of hurdles for medical professionals. So we need to be very safe to start with this kind of procedures. So ethical committee as well as medical legal help has to be sought before we actually start these procedures.
Correct.
Absolutely right, Dr. Ravi.
Absolutely. I think most big institutions have very good ethics committees now. So I think that permission is a must. And if the associations like FOXI, IAPS, IAP can address this issue and get some legal permissions or guidelines implemented, that will be a great step.
Dr. Mohan is there. He was commenting in the chat box right now. I think he is there.
I think we had asked him to be unmuted.
Maybe they have not found him in the, but he's replied right now. He is in the chat box where he has mentioned that pediatric surgeons are entitled to operate on fetus with congenital anomalies.
I'm
Yes.
just promoting sir to panelist. 1 minute.
Okay, please promote him. We will be happy to hear him in person. But because he is also on the verge of, embarking on this fetal surgery journey. Dr. Mohan.
He's trying. He's still not being.
Yeah,
Okay.
Dr.
Promoted.
Mohan has been doing
Meanwhile,
fetal surgery
as
for
he
a while.
comes on,
Yeah, he's there. He's there now.
is there? Hi, Mohan. Can you? Dr. Mohan,
I think he needs to be unmuted by.
can you unmute
Okay,
yourself?
can you hear me now?
Absolutely,
Yes.
Mohan. Good to hear you. Your comments and thoughts about.
Yeah. I mean, it's a nice discussion. Now, one thing about the medical legal issues, we are doing many of these procedures in Amrita, from simple things like TTTS or amniotic band syndrome to fetal endoscopic PU valve ablation, etc. So as pediatric surgeons, as per MSA rules, we are entitled to operate on congenital anomalies. So that includes the fetus. Now, the point, the medical legal issue comes up, PNDT Act also comes there, is because we are not entitled to do any procedure, any endoscopic or any diagnostic ultrasonological procedure on a pregnant woman. So for that, you have to register with the PNDT. So that is a problem. So as they said in the beginning of the talks, it is a team effort. So I operate with the fetal medicine person. We all scrub together. And sometimes it is a difficult thing. There's we even get in the pediatric cardiologist to monitor the heart. Well, most of the time the fetal saturation is only about 75%. And if it drops below that, most of our sensors don't pick it up. So we have to go by the cardiac output. So it's a team effort. And the neonatologist is the most important person. I mean, our incidence of prematurity is slightly higher. I don't know why. I mean, it is high. I mean, we always tell the parents that this is the one thing that you will have to face. Your child will be born a little premature, maybe 36 weeks, maybe 35 weeks. Sometimes even we had them being born at 31 weeks or so. So that's a problem we had to take. And one thing I wanted to tell is, don't ever try to convince the parents.
Yes.
I mean, that's the biggest mistake I think a fetal surgeon or a gynecologist can do. My wife is a gynecologist, so I tell her the same thing also. That never convince. I mean, put the things before them. Like myelomeningocele, you can have a 50% reduction in your hydrocephalus. Your chance of the child walking without support is 50% more if you do it than if you don't do it. So put it before them. Let them take the decision. Because I've seen mothers, agreeing for something and then later repenting about it. And so we should not take the decision for them, especially in myelomeningocele. If it is a lethal condition like a sacrococcygeal teratoma which has gone into high drops, or a CPAM that has gone into high drops, if you don't operate, the baby will die. The mother also may get into problem, like with the mirror syndrome. So there you are justified in convincing the parents. But non-lethal condition like myelomeningocele, leave it to them. Let them decide. In our country, most of them will opt for a termination of the pregnancy. So, I mean, you can't stop them, because everybody asks the same question. I mean, the parents ask me the same question. Can you promise a normal child? The answer is no. Then it's up to them to decide.
Absolutely. I think I completely agree with you, Mohan, that honesty is the best policy. Put the cards in front of them. And that's what actually we do even after birth, when we operate on these spina bifida patients postnatally. That time also, when we do the back closure, we have to be very honest and tell them this is closure. We don't know what's going to happen. And so similarly, we have to be very careful that we don't push fetal surgery onto the family. And that's what I think Dr. Agnieszka also said. We have to be honest. And One good way I have found when trying to talk to patients after birth is to tell them this is the situation, meet a few more families who have undergone this, and then take a call. Don't decide just because I am telling you. In fact, I go to that extent to tell them, don't decide because I am telling you. Meet a few more families. Maybe a day will come when we can say this about fetal surgery having been done in a few babies. So I'm sure Agnieszka tells them, please meet these 4 families who have undergone fetal surgery and take a call. So that stage we probably might reach in the years to come.
I believe that if what I tell them, if they are decided on continuing the pregnancy, and if the ultrasonography wise there is no other anomaly, and if the feet movement of the feet are there, foot movements are there, then it is better for them to go for an antenatal surgery than go for a postnatal surgery. But choice between termination and fetal surgery is entirely up to them.
Absolutely. So I think the consensus is clear that it can be offered as a clinically viable option. And if we were in Katowice in Poland, it would be the gold standard where they will say that that is the first thing to do. So we have some catching up to do, which we hope this never-ending pandemic will allow us to catch up sooner than later. But a last question from the audience, and which has been asked by many, and I want both Dr. Anita and Agnieszka to re-emphasize, what is the right time to operate on the fetus is a many times asked question. So you have mentioned that in your talk, I know, but many people again want to know what is the right time to operate on the fetus. This will be the last question and answer. And after that, I am going to request Dr. Mr. Rohit Shelatkar to give his closing remarks. So Dr. Anita and Agnieszka.
I think said that the best time, the time which is the best is between 21 and 27 maximum, but we decide to operate about 24. It depends on the consistence of the fetus body. When the fetus is very small, his body consists mostly of water, so it is difficult to make the surgery. Fetoscopic procedure are done a little bit earlier, as far as I know. But we, for example, receive the patients from the other center in Poland. The fetus was 26, and it wasn't possible to do it fetoscopically, so we did it by fetal open surgery. Agnieszka, would you like to add something?
I agree with you, and as generally the fetoscopy 2 weeks earlier, 1-2 weeks earlier, because we need a space during the fetoscopy, and the space between fetus and womb walls is bigger between 23 weeks than over 24. But for the open fetal surgery, in my experience, not earlier than 25 weeks, because these few weeks really change everything. During the fetoscopy, you have a better view because everything is much bigger than in real. So it's easier to perform it earlier. But when it is over 25 weeks, it's the fetoscopy is very, very difficult to perform because of the small spaces.
Okay.
Small
One
spaces.
more allied question. Does prematurity depend on the time of the surgery? So since we are talking of timing, does prematurity depend on time of surgery? Will it be more if you operate later or earlier?
No.
Too late.
The maturity doesn't depend on time of surgery, but the chance for the fetus can change. The later we operate, the better chance, yeah, because it is very difficult to save the child at 23, which, for example, is born after the surgery, unfortunately, but it is much easier to save the child 26 when the premature delivery happens.
But we haven't found a connection between operation performed between 22, 23 or 24, 25 weeks. In our experience, there were no any connection with the premature labor.
Yeah, so with that, we will close the question answer session. Do I have the permission of panelists to do that? Anybody wants any quick comment or last closing remarks? If not, then let me invite Mr. Rohit Shelatkar. He has been listening to our discussions, and let me ask him to give the closing remarks for today's webinar. Mr. Rohit Shelatkar, please.
Can you hear me?
Yes.
Thank you, Dr. Karmarkar. Thank you, Dr. Pastuska. Thank you, Dr. Oliek, for your knowledgeable and informative presentations on fetal surgery. It is amazing to see the fantastic work you continue to do and the lives you improve day to day. Dr. Pastuska underlined that spina bifida is the most prevalent malformation of the nervous system and second, more frequent congenital after heart defects. This is very less known to general public and even in the field of medicine. Our speakers have explained how we can treat fetus by untethering the spinal cord and the nerves and separating the spinal cord and spinal nerves from the toxic effects of amniotic fluid and the mechanical damages associated. In addition to this, we can help reduce the effects at a greater extent by ensuring women at fertility age follow a nutritious diet and incorporate supplements like folic acid, B12, vitamin D into their lifestyle. Of course, in cases where spina bifida cannot be prevented, then we have expert surgeons like Dr. Pastuska, Dr. Oliek, Dr. Karmarkar, who achieve the goal surgically before the baby is born. Through this presentation, we also saw how operating on the fetus before birth for MMC gives a better chance for motor development by increasing the stability and mobility in the hip joints. The panel also touched upon legal and social aspects towards the end, which was incredible and one of the most important aspects that we should discuss and talk more often, and maybe push regulators to relook at regulations to make knowledge more available and surgeries easily achievable. The speakers have also shown us how prenatal MMC repair can reduce the risk of inflammatory changes in the spinal cord at a significant rate, and that the condition of the urinary tract was improved by prenatal MMC repair, therefore improving social urinary continence and combating the risk of constipation, etc. Children who benefit from these operations can look forward to a better quality of life and highly esteemed, self-esteemed and independence, which is most important. So thank you again, Dr. Anita, Dr. Pastuska, and all the panelists. It was really thought-provoking and a real eye-opener. Above all, I would like to thank our colleague, a very good friend, Dr. Karmarkar, for organizing this amazing webinar and founding the Spina Bifida Foundation India. From a nutritional point of view, I cannot stress enough the fact that we can prevent most cases of spina bifida and many other birth defects by ensuring women of fertility age follow a nutritious diet and incorporate supplements like folic acid, vitamin B12, vitamin D into their lifestyle. So with that, I'll thank you all. It was a wonderful event and hope to participate in many more of these kinds of events in the future. Thank you.
Thank you, Rohit. And once again, a big thank you to all the speakers and panelists for what I think has been a very, very interesting couple of hours and very informative, and probably will be the harbinger for more teams to start fetal surgery and make a beginning, look at medical legal issues, ethical issues, and take this ahead. I also want to put on record a big thank you to my department of pediatric surgery, Leelavati Hospital, all my colleagues, Dr. Redkar, Dr. Nathani, and Dr. Anand Bangar, and our excellent team of residents who have always been helpful and supportive for all the activities and the work that we do in the department. Spina Bifida Foundation, which we started some years ago, is making rapid strides. We have now state chapters in 14 states, and we hope to reach out to more and more families who have either fetuses who have been detected to have neural tube defects, or who have children who are born with spina bifida. So I must mention that in spite of all the knowledge that we have about prevention, the awareness in this country is still very low. Every week I get through our helpline, I'm now doing about 3 or 4 video consults from remote villages in UP, in Meghalaya, in Haryana. And it's amazing that a few days back, a 22-year-old girl who was born with spina bifida in a remote village in UP fixed up a video consultation with me for her incontinence. So I think we are reaching there, a long way to go, but I was very impressed that this farmer's girl, she had been operated, her back had been closed. This part of her state is near Uttarakhand. So she went to Dehradun, got her back closed at the age of 6. And then her orthopedic surgery was done in Dehradun. From there, she got to know of our foundation. And when she rang me up, the first question, she thought that we were from outside India. And she said, "Sir, up India mein ho ki bahar ho?" I said, no, we are very much in Mumbai. And so she did a very confident video consultation. So I think India is getting there. Technology is reaching villages. So maybe a few centers of maternal fetal surgery is definitely on the cards. So thank you very much for the participation, the support. Also thanking IAPS and Dr. Ramadhan and Foxy and Dr. Shanta Kumari. Thank you very much. I cannot end without mentioning Mrs. Uma Kalekar's name, who is in charge of the Mayor Vitabiotics in India and in some Southeast Asian countries. And she is really there for us in Mumbai whenever we plan events like this, and supports the health that we can provide to patients and families across India. So I look forward to your support for the foundation. If any of the obstetricians have a child with a neural tube defect, please count on us. We want to extend a helping hand, not just to operate on them, but to rehabilitate them and to make them productive members of our society. So thank you very much. And thank you, Rohit, and all the others. Thank you.
Thank you.
Thank you, Dr. Karmakar.
Thank you.
Thank you very much for the invitation. It was very nice to see you all.
Yes. And we hope
for
to
future cooperation.
We hope to see you in Mumbai very soon.
Yeah,
Okay.
we hope to.
We hope. Okay.
Thank
Thank
you.
you, Doctor.
Thank you, Santosh.
Thank you, Dr.
Thanks,
Karmakar.
everybody.
Thank you.
Thank
You,
you.
Mohan.
How do you join the foundation?
The Sneha will contact you
Okay.
soon next week. She is
Okay.
our chief coordinator, and she is working behind the scenes seeing that things are happening.
You're
So
doing a very good work.
thanks a
I mean,
lot.
that's real philanthropy. You know.
Yes.
Yes. Thank you, Professor Janusz.
All the
Or-
time, we also invite you to Poland.
Yes,
To see
I'm
our
waiting
surgery in
to.
Poland.
I'm waiting to travel. The first opportunity I get,
Everyone is
and
waiting.
everybody is waiting.
Everybody is
Professor
waiting.
Janusz the whole panel will come. The whole panel will come to Poland. Yeah, good
Thank
idea.
you.
Let's
Thank
plan.
We are all ready.
You have organized fantastic conference.
Okay.
Bye.
Thank you very much. Bye bye.
Bye-bye.
Bye bye.
Bye-bye.
Thank you.